briefly introduce myself, Combat Medical, and give you some details on today's meeting before we move on to Dr. Sousa's presentation and the Q&A. So my name is Sarah Bruce White. I've been with Combat Medical since its conception in 2012. Combat has multiple CE mark devices used in oncology, including the BRS, which delivers HIVEC, or heated chemotherapy. HIVEC is used to maximise the patient benefit safely and with good tolerability in non-muscle invasive bladder cancer patients. So we have over 800 patients in clinical trials, have conducted over 40,000 treatments, have had 5 publications and over 25 abstracts presented over the last 5 years. As many of you will know, HIVEC is used successfully in different patient groups and different protocols, as evidenced by the fact that there were 3 separate presentations selected for this year's AUA, all with different patient cohorts and different treatment pathways. We have in the meeting today, thank you everyone, urology professionals and our distributors from many different countries. So I just wanted to confirm a few things. So in this meeting, as most of you will be familiar with Zoom anyway, we're going to ask everybody to mute themselves to preserve the sound quality of the meeting. The presentation will be in English, but my colleague Mariam, thank you Mariam, will be on hand to help with any translation if required during the Q&A. So to keep it simple, if everybody can type their questions into the chat function, which is on the bottom Zoom taskbar, feel free to type the questions in at any point. We won't be addressing them until after the presentation, but if you keep them coming, they're ready to go as we finish the presentation. So again, depending on bandwidth, might be necessary to turn off videos, put the speaker view on, so you can see Dr. Sousa. Again, we'll sort of modify that as we go. If you want to turn your videos back on later during the Q&A to ask, if we're looking at one of your questions, feel free to do that, although do be mindful we are recording this and sharing it. That is quite enough of me talking, so I'm going to pass on to Dr. Sousa to run through the slides. I'm going to be sharing the screen, so Dr. Sousa, if I need to move a slide, please just let me know. Thank you very, very much. Okay.
Well, good afternoon to everybody. Thanks for sharing this time to hear this presentation. So Sarah also read the title, and was our experience with chemoresection with intravesical installation versus the standard treatment in patients with intermediate to high risk non-muscle invasive bladder cancer. This work was done in the Infanta Sofia University Hospital of Madrid and the Comarca Hospital of Monforte, where I work. Next. Well, what is the rationale about the use of the neoadjuvant chemohyperthermia in non-muscle invasive bladder cancer? Well, this is based on the concept of the immunogenic cell death. Everybody knows that some kinds of antineoplastic treatments, including chemohyperthermia, may destroy tumoral cells by immunogenic cell death. We hypothesize that the neoadjuvant chemohyperthermia may stimulate the patient immune response, acting as a vaccine against cancer. Please next. Sarah? Sarah? Okay. Well, it was a phase 3 comparative, prospective, randomized, controlled clinical trial with mitomycin. And was designed to compare the efficacy and tolerability of neoadjuvant chemohyperthermia with 8 neoadjuvant weekly doses of 80 milligrams of mitomycin, recirculating at 43 degrees with the bladder recirculation system of Combat Medical, and was compared to another group that was treated with 15 passive normothermic standard adjuvant doses, which was 4 weekly and 11 monthly, and was performed with 40 milligrams of mitomycin after TURBT. The primary endpoint of the study was the 24 recurrence-free survival of the neoadjuvant chemohyperthermia compared with the standard treatment. Secondary endpoints were efficacy of neoadjuvant chemohyperthermia in terms of complete and partial response, pathological response after 4 and 8 doses of the treatment. Tolerability, quality of life, and cost effectiveness of the neoadjuvant chemohyperthermia was compared with the standard instillation also. Please. While the inclusion criteria were histological confirmed previous urothelial cell carcinoma, non-muscle invasive bladder cancer following recurrence of a G1 to 3 PTA or G1 to PT1. The number of tumors have to be 6 or less and the age 18 or older. The exclusion criteria were patients with solid tumors, muscle infiltrating aspect of the tumor or suspicious of the carcinoma in situ, positive cytology, and recurrence of previous T1, G3, or carcinoma in situ in the last 12 months. Well, calculating a 45 recurrence risk average of intermediate and high risk of the non-muscle invasive bladder cancer, a 5% alpha error, 80% statistical power of the study, and an estimated rate of follow-up loss of 5% of the population, we needed for each arm 54 patients. So between March 2015 and June 2019, 68 patients were treated at the Infanta Sofia University Hospital and the Comarca Hospital of Monforte, and the mean follow-up was 38 months with a range between 4 to 54 months. The results of the initial pathological response after the TURBT in the neoadjuvant chemohyperthermia arm, 20 patients showed complete response. So there were no tumor at the tumoral at the resection of the tumor of the TURBT. So this means 61.8% of the patient. 10 more patients showed 29.4, about 30% of the patient showed partial response meaning that the patient has a diminution of the tumor, the number of the tumors or the size of the tumor higher than the 50% of the original location or size. And 3 patients showed no response, which is about 9% of the patient. After a follow-up of 38 patients in the neoadjuvant chemohyperthermia arm, 20% of the patients showed recurrences. And one of the patients showed a progression, but only to a T1, G3 tumor, not to an infiltrative tumor. In the standard mitomycin arm, as opposite, there were 38% of the patients showed recurrences, and 3 of them were, which means 9% of the patients showed local progression, and 1 of them showed also muscular invasion. It was a T1, T2, G3. These differences were statistically significant for the recurrence, P under 0.02, superficial recurrence, P under 0.05, and muscular progression, P under 0.01, please. Well, about the tolerance and adverse effect in both groups were similar. In the neoadjuvant arm, about 53 of the patients showed grade 1 to 2 adverse effect, which mostly were irritative symptoms, bladder spasm, pain, hematuria, urinary infection, mitomycin allergy, the typical symptoms or adverse effect of the mitomycin treatment. And only 3 of them, which is about 9%, showed grade 3 adverse effect, which include bladder retraction, bladder calcification, and urethral stenosis. In the other group, the standard mitomycin arm, 44% of the patients showed a grade 1-2 adverse effect, about the same kind of symptoms, and 2, which was 6% of them, showed grade 3 that included a bladder retraction and a urethral stenosis. So the conclusion is that 60% of the patients show a complete pathological response after neoadjuvant chemohyperthermia. When we perform the TURBT, we find that 60% of the patients, actually some little more than 60%, have no tumor at all. And the recurrence and progression of rates after a follow-up of 3 years were significantly better in the neoadjuvant arm. Obviously, further studies are needed to confirm the protective effect of the neoadjuvant chemohyperthermia against tumoral recurrence and progression. Please. Well, what about the rationale of the neoadjuvant chemohyperthermia, how it works? Well, the idea is that if you have a bladder cancer and you apply, please, next, neoadjuvant chemohyperthermia, it will produce cell swelling and rupture that will show in the surface mainly Headtohead proteins 70 and 90, and this was the characteristic of dying tumor cells. Well, these cells after break will liberate calcium-reticulin, ATP, and high mobility groups, group box 1 that will stimulate the immature dendritic cells to transform, please, into a mature dendritic cells that will are able to make up antigen presentation to the rest of the immune cells. Well, these cells are, for example, the CD4 plus T cells, and this will produce a complete Th1 cell response that among all these characteristics included the natural killers that will infiltrate the tumor, destroying the rest of the tumoral cells that were not destroyed by the chemohyperthermia itself. So this immune response will create a memory that will help the patient to avoid next future recurrences. Please, one. So this is the line. The neoadjuvant chemohyperthermia causes immunogenic cell death and generates an immune response that increases tumor-free survival. So this is the initial of this study. Of course, it has to be followed for more studies to really demonstrate that this rationale is true. But the initial results are really very exciting. So thank you for hearing me, and now I am open to any question that you want to do.
Dr. Sousa, thank you very, very much for sharing that. That was a great presentation. So I'm hoping that there's been lots of questions come into the chat, and that if I do that, that doesn't overtake my screen if I'm sharing. So bear with me 1 second, because at the moment, if I go into the chat, could please, if people can pop their questions in there, that would be great. So I'm wondering if now I've got the chat up, whether everybody can still see the slides. Alex?
Yeah.
Yep. Okay, that's absolutely great. Has anybody got, oh, sorry, I'm still sharing and just trying to manage the, okay. Okay, so thank you, Hazel. Obviously, you've thanked us very much for sharing. And I know that there was a couple of questions I'm going to just let give everyone a couple of seconds to type those into the chat. So I can, okay, right, there's a question come in. Alex, I'm going to read these out to you. If for any reason they're unclear, let me know. So how do you grade the tumours before starting neoadjuvant therapy?
Well, actually, we don't know exactly, but most of them have biopsies, cold biopsies in the cystoscopy performed at the origin, at the moment of the diagnosis.
Okay, thank you very, very much. So I'm going to go to Hazel's question, then come back to John Witch's question in a second. Hazel Warburton, thank you, Hazel. Given that patients have a much shorter course of treatment, is the toxicity greater?
Well, actually not. If you saw the slide about talking about the adverse effect, were practically the same. Is really a little increase, but only adverse effects grade 1 or grade 2. In the case of the grade 3, there were 3 in one group and 2 in the other. So this is absolutely not different statistically. So this is not really a problem. In some cases, well, maybe the tolerance of some patients is a little problem, but if you talk to the patient, you increase the temperature slowly to achieve the 43 degrees in 5 minutes, not in just 1 minute. The patient tolerate the treatment very, very good in most cases. But if you have to use maybe some medicaments to anti-inflammatories or anti-spasmolytics, is perfect. The tolerance is not really, in my experience, is not a problem with this.
Okay. And then, so a very quick question before from John Witch, who wants to know whether you've run any head-to-head studies against standard BCG. So, John, I presume that you mean not just HIVEC versus BCG, because we have a HIVEC HR study, but I presume you're meaning, has there been any neoadjuvant versus BCG?
Yeah, really, if you have to run a head-to-head with against BCG, it has to be with high-risk patients, because if not, it has no meaning, you know. So you have to use T1, T3, and carcinoma in situ patients. So in this moment, we are not starting any of this kind of treatment, but we have some experience with patients with T1, T3, and even with carcinoma in situ, but treated as adjuvant. The chemohyperthermia was performed as an adjuvant treatment and not as a neoadjuvant treatment as we perform in this study.
Brilliant, thank you.
Just to add to that, we have not in a neoadjunctive study, but we have, as you say, Sarah reported last week on adjuvant high-risk trial, which excludes carcinoma in situ, which was HIVEC, so TRB and HIVEC versus TRB and BCG in high-risk patients alone.
I've put the link in the chat to Felix's talk a couple of weeks ago.
Brilliant. So thank you, and we can send around further details. So obviously in this study, you've got an 80 milligram dose in the HIVEC arm and only 40 milligram in the standard arm. Why 80 milligram, and do you think this is optimal? Dr. Sousa, if you could talk through that, please.
Well, the standard treatment, adjuvant treatment with mitomycin is 20 milligrams in some countries and 40 milligrams in the rest of them. But this is completely different, because when you are performing an adjuvant treatment after a TURBT, it's supposed that there are no more tumor inside the bladder, or maybe there are some cells floating if you perform an immediate after the surgery. But this is totally different. You are treating a tumor that is still complete in the bladder. So this is why we use higher doses. And the previously published paper have used the same. So we considered that this is the optimal doses for neoadjuvant treatment, which is different than adjuvant.
Thank you, Dr. Sousa. That's great. So another question from Hazel. Thank you, Hazel. Given you present the effect as an immune response, what do you think the role is for maintenance?
Well, the maintenance is if you believe that you are created an immune response with this, the idea, maybe this is just a comment that I have in my mind in this moment. Maybe you may do the maintenance even with BCG, because you are treating to maintain an immuno response and an immuno memory. But in my opinion, all the patients that I have treated with neoadjuvant chemohyperthermia and showed no tumor, PT0 at the TURBT, most of them did not have recurrences in 3, even 5 years of follow-up, because I have some of 5 years of follow-up without recurrences. So in my opinion, I am not going to do anything else until they have a new recurrence. If they don't have it, I don't have the idea that I don't need to touch them.
Okay, thank you very, very much. Thank you, Dr. Sousa. So I've got a couple of questions that have come in to me privately about, so how do you confirm a complete response?
Because we perform, after the neoadjuvant chemohyperthermia, we perform a TURBT. Of course, any lesion that you may see in the bladder, but moreover, we perform biopsies of the tumor, of the places where the tumor was located before the treatment, even if there are nothing. And if you can see any lesion, anyway, we perform a biopsy of this place to confirm that the patient is really a T0. There is no residual tumor.
Perfect. Thank you very, very much. Okay, so are there any future trials planned? And you may want to answer this, and then I don't know if Edward's on the line, maybe he wants to add, but if I can let you answer that first, please. So,
say it again.
Any future trials planned? So
yeah, we are thinking about that, and including, you know, in the secondary endpoints, we are and the parallel studies that you perform during a trial, we are trying to measure some immune response markers as the calcium or immunoglobulin EL6, some others. You know, the idea is to prove that there really exists an immune response.
Fantastic, thank you. Edward, do you want to add anything to that?
And beyond that, we are planning, as Alex says, a study which we call HIVEC 3, which will look at the immune response, and we'll also in that study run the trial using epirubicin and gemcitabine, so we have both safety and tolerability data in a controlled trial, looking and comparing both cold versus hot as well, so we can compare directly. And once we've finished that study, we will then actually expand that study with either certainly mitomycin, given the results in these trials, but certainly potentially, hopefully, at least one other drug where we will do a phase 3 trial and look at a much wider group of patients, and we'll have it randomized against standard of care for this group, so we can actually have a phase 3 trial to see whether this becomes a main option for treating in the future for recurrent, low-grade recurrent patients. So that's a trial that we are looking to hopefully launch towards the end of this year or early in 2021.
Brilliant, thank you, Edward. Christine has asked me a question which I'm going to come back to in a second. Out of the, there's Hazel's another question for everyone. Out of the context of a trial, are you happy not to perform biopsy to confirm complete response? So that's out of a trial context.
Well, this is a nice question to answer because sometimes when I perform a cystoscopy after the neoadjuvant treatment, there are no tumor at all in the bladder. So in these cases, my idea is just to take a cold biopsy of the original location of the tumor. And if this is free of tumor, I think that you may consider that really is a T0 and not needed to perform a TURBT with anesthesia and everything.
Okay, thank you very, very much. So Alex, we created a HIVEC flow chart, which was probably not in your presentation, where there was 3 different exploratory arms based on a HIVEC with no response. I'm just reading Christine's question. So we're presenting here a single treatment arm. Christine, the difference here is that the 3 arms represented a complete, a partial, and a no response. So apologies there. If that's not what you meant, please message me again. I'm just going to the next question, which has come up privately, which is, what do you think are the barriers to getting more patients treated neoadjuvantly? Because it's not a standard protocol to follow.
Well, actually, it's very difficult to change a paradigm, something that is working. We don't have the idea to change for a new treatment if we don't have really a necessity to do it. Yeah? So intermediate, low risk, intermediate risk, and some high risk patients are correctly treated with TURBT and followed by adjuvant treatment, BCG or mitomycin, but the results are not exactly what we want. The results, the recurrences still being high, the progression is still present, especially in the high-risk group. So I think that we need to explore new paradigms, new options, and mainly because this may create an immune response that will protect the patient in the future. It's not only a treatment for today, it's a treatment for today and for tomorrow. So, of course, it's difficult to change the usual, the standard care of our patients, but I think that that we have to change something if we want to improve something. If not, we are going to do the same for decades. So, in my opinion, the neoadjuvant treatment has, and of course, we use it in many infiltrant tumors. For example, muscle-invasive bladder cancer, we perform neoadjuvant chemotherapy before the cystectomy. So we perform it before a cystectomy, and why we may not do it before a TURBT? So this is my opinion. This is a question that have to be first studied in some trials, and then try to use it in the standard care. Okay,
thank you very much. So in terms of paradigm shift, you know, life is certainly certainly different at the moment. So, and I don't know if this is the case in Spain, but reports certainly from the UK is that obviously there's going to be a big backlog of patients waiting for surgery for TURBT and maybe, you know, a reduced capacity, you know, with all the, you know, additional hygiene and COVID measures. So rather than a watch and wait, you know, would you suggest neoadjuvant as an option to try, and if so, in which patients? And I'm just sort of throwing that out to you, and if anybody else wants to comment on that after Dr. Sousa, please feel free. So, Alex, so what patients, if you had some patients that were literally not going to be treated for 9-10 months due to backlogs,
but
you know, which patients
is the best patients for be treated with neoadjuvant chemohyperthermia? This is the question, maybe?
Yes.
Okay, well, in my opinion, the low-risk patients, you know, a PTA, G1, and that is the first two lesions in the bladder, and this is the first presentation, it has no meaning to do that, you know? We have the standard care is more than enough. And in the high-risk patients, I think that it will have a good indication. So the idea is starting in the medium high risk because the patients that may take the best, the better advance or that may be have something to gain with the treatment is the moderate to high-risk patients, you know, especially those that we have with a high number of recurrences, very short, maybe under a year. These kind of patients will really have a good result with the neoadjuvant chemohyperthermia. This is my opinion, because you have to prove it with a trial. But in my opinion, these are the patients that were the best to try with this treatment.
Fantastic, thank you. And would, again, it's a little bit, you know, sort of going over that, but would you say, from your opinion, it's an acceptable alternative to free up OR space in this current climate?
Say it again.
Is an acceptable alternative to free up the OR space, the operating room space, and then we'll go on to discuss other drugs.
Yeah, well, it depends on some hospital has had problems to perform this treatment to many patients, because you have to have the patient during 1 hour occupying a space, and you have to do it during eight times. So if the hospital has the possibility to do it, at least we'll have a 60% of them will not need a TURBT. Maybe just with a cystoscopy, ambulatory cystoscopy, and with a cold biopsy, maybe will be enough to demonstrate that the tumor was totally destroyed, and the patient don't need to perform a new surgery.
Okay, no, that's brilliant. Thank you very, very much. Other questions coming in about, obviously, in some areas there is still a mitomycin shortage. So what about other chemotherapy drugs, if you do have in your area a mitomycin shortage?
Yes, of course. We have no experience or few experience with the gemcitabine or other chemotherapeutics, but really the results, at least in the not clinical, but in some studies, the synergy with other chemotherapeutics agents are even better than with mitomycin. So there is no reason to use only mitomycin.
Perfect, thank you very, very much. So I think I'm coming towards the end of my questions. Sorry, I'm just scrolling through the questions to check that I haven't missed any, because some come to the group and some come privately. So if anybody's got any other questions they would like to send into the chat, please do, while I just scroll through and check that I haven't missed anybody else's questions. Again, you know, if anybody wants to ask anything about, you know, the choice of number of treatments, I don't know if you want to add anything about why specifically 8 weekly, Dr. Sousa, again, you know, sort of different to other protocols where they do, you know, 6 weekly, for example.
Well, this is the question, yeah, about the number. Well,
Yeah.
We are using 8, and in my opinion, the minimum is 6. Why? Well, the experience that we have with the BCG for many, many years is that until 6 doses, 6 weekly doses, we have not achieved an immune response completely mature to, you know, to destroy the tumor. So maybe we perform a cystoscopy at after 4 treatments, and in some cases only with 4 doses was enough to destroy totally the tumor, but most of the patient received the total treatment of 8 weekly doses. But in my opinion, 6 is the minimum.
Okay, thank you. So again, there's been a comment come in that they've never had a complete response with using just 40 milligram and 6 doses. So again, based on your findings over this long period of time, mean sort of follow up 38 months, and 80 milligram and 8 weekly treatments would be optimal based on your findings.
Well, I have no answer about the exact doses or the perfect doses, but the number of doses have to be minimum, in my opinion, 6. But the amount of mitomycin you have to use, well, we use it 80, but maybe if we perform a trial comparing 40 against 80 milligrams, and maybe it's the same or close the same. This is something that I don't know exactly, but moreover than the price of 80 milligrams, there were no problem of toxicity with the 80 milligrams. So we prefer to use the 80 milligrams doses to achieve a better and longer response.
Okay.
And if I can just add to that, one of the other reasons we use 80 milligrams is because we have a priming volume within the set of 35. So it means by the time that you add the dose direct into the bladder and the dilution of the set, it comes to 80 milliliters. So it means we're actually giving a similar concentration of 1:1, which is in the recommendation. And so again, we were trying to make sure that we weren't disadvantaging the HIVEC arm. We do have some experience, again, this is anecdotal, in America, where we had a humanitarian use. We've treated about 30 patients in the US, and we followed the US protocol, which is using a 2-in-1 dose. So we actually used 120 milligrams in the priming. So a very high concentration, higher concentration than anywhere else. This wasn't a trial, this was an IND. But,
and it wasn't neoadjuvantly, it was adjuvant, sorry. Just
adjuvant. But we didn't have any tolerability issues, but it wasn't a trial, but it was 30 patients. So we have used it in very high concentrations because we had to use exactly the same dose. So that's anecdotal. So we have used it elsewhere, but we're trying at the moment just to make sure that we're at least matching the existing 40 milligrams and 40 mLs.
Thank you. There was another question. Obviously, neoadjuvant, it has a proposed immunogenic effect. So somebody in the chat would like to know which data in the trials, helps support this best, the proposed immunogenic effect.
What moment to do the treatment, or to what?
So
exactly?
which data show, which bit of the data would you say supports the immunogenic effect of neoadjuvant best?
I think that the longest time to recurrence and the disease-free survival is higher. So this means that it's a memory that is protected in the future. This is, for me, is the main data that favor this idea.
Brilliant. Thank you very, very much. I have come, and I've just scrolled through, and apologies, please feel free to turn your videos on and shout at me if I have missed your question, because there was a few coming through. But if there's no more questions, then we will go to the stage of wrapping everybody up and thanking everyone very, very much for their time. Dr. Sousa, anything else you would like to add before we thank you and everybody else for joining us this afternoon?
Just to say thank you to the people that was hearing this presentation, and just invite them to cross the line and change the paradigm of the TURBT followed by adjuvant treatment. I think that the neoadjuvant chemohyperthermia induces a response that it will protect our patients in the future. And this is something really very important.
Brilliant. Thank you very, very much, Dr. Sousa. And thank you everybody else for joining us from around the world. Thank you very, very much. So the recorded presentation will be available soon, and I will send also the slides around to everyone that was registered, and a survey for feedback. Obviously, it's always nice to be able to improve. If anyone suddenly thinks of any questions, please feel free to email me, and we will provide the answers to those at a later date. We will continue to share our clinical data through this medium for the time being, so please do watch out for any other communications regards other webinars we'll be holding, HIVEC versus BCG failure and other data. But otherwise, everyone stay safe and well, and thank you very, very much for joining us this afternoon. It's very much appreciated. So we will end it there. Enjoy your evenings, enjoy the rest of the week and the weekend. So thank you very, very much. And thank you, Dr. Sousa. Thank you. I'm going to stop the recording in a second and stop the meeting.